Okay, welcome to the second annual meeting of the Cochrane Bias Methods Group. The first one was yesterday, and my name is Asbjørn Hróbjartsson. I'm a co-convenor of the group, along with Isabelle Boutron, Julian Higgins, and Matt Page. And the agenda for today is a short welcome from me, a presentation by Silvia Minozzi on a qualitative study on the use of grade and cinema. After that, I'll give a short presentation of the group's activities for the last year. And then at the end, we will hear a presentation by Giorgia, Sulis and Cassandra, Laurie on the improving risk of bias assessment and reporting in vaccine effectiveness research. Cassandra, Laurie and Giorgia Sulis are placed in Canada, so I just want to acknowledge the fact that it's 3 o'clock for them, so well done. Each presentation is a 12-minute length with 8 minutes discussion. Housekeeping, the meeting is recorded and we'll make it public on the group's YouTube channel. After the presentation, if anybody wants to comment or ask a question, please raise your hand and I'll try as to best of my ability to steer that discussion in the right direction. Another possibility is to write a question or comment in the chat, and Christopher will summarize those questions during the meeting. So, without further ado, I'll pass on the mallet to Silvia Minozzi, who will present a qualitative study on the use of grade and cinema. You are muted. Maybe if you try to reconnect with us and see whether that improves matters, because we can't hear you.
Let's just give her a moment to try.
We can't hear you. I think it doesn't really make sense. Maybe we should change plans and Christopher, maybe I'll just present first and we'll see whether Silvia can get sound on her equipment.
Sure.
So, activities for 2024 and 2025, the Cochrane Bias Methods Group. I'll try to keep this short. It's tradition that we present the conveners and the group coordinators present the group's activities and sketch plans for the next year. So next slide, please. So we have grown. There are 652 on the mailing list, over 2,000 Twitter, and we send out 2 newsletters every year. Next. The main activities with regard to tool developments have been the Tacit tool and the second version, version 2 of the Robin's Eye tool. And Tacit is a tool for addressing conflicts of interest in trials. It's a new tool, and I'll present a couple of slides later on to go into slightly more depth and detail, because the tool is almost ready, and the plan is for publication within 4 or 5 months or so. And the Robin's Eye second version has been expanded and developed. The Robin's Eye has been built on the Robin's E, the experiences from Robin's E. Yeah, next. So conflicts of interest have been an issue for trials to be included in systematic reviews for several decades. And the idea behind Tacit was to have a structured guide for systematic review authors for the collection, processing, and interpretation of information on conflicts of interest and funding sources in included trials. So the tool provides a just judgment whether there's a cause for what we call notable concern about conflicts of interest, but also an assessment of the quality of that information. And it's part of the raison d'etre for that tool to steer away from having considered this a bias. It's a general notable of concern, which complements ROB2, but doesn't define it as bias as such. Next. So it was based on a fairly comprehensive development process for studies, supporting studies, steering group and a working group. And the reason I'm talking about it now is that a near final version was made public just last month in OSF on the project website, tacit.1, and on the Bias Method Group website. And the idea is for people to have a look at it and maybe use it for their systematic review, and provide feedback for us to revise an ultimate time, and for them to submit for publication in the spring of 2026. Next slide. Beside tool developing, there's been a fair amount of training activities, workshops on risk of bias in non-randomized studies, webinars on Robin's Eye, on RobMe, a Cochrane Methods clinic about ROB2, and the group is available to support Cochrane reviews. Next. Besides what could be called core project, we have a number of collaborative projects, especially with regard to reporting guidelines. The Spirit 2025 and the Consort 2025 version came out in the BMJ this spring. We are working on a reporting guideline for protocols for systematic review, updating the Prisma P. Probably a new version will be available in 2026. And the risk of bias in network meta-analysis was published in the BMJ also in 2025. Next. So plan for core activities next year. The publication of Tacit is one. The revised version of Robbins I will be the second, and we've just started up a third project, a living review of AI tools for risk of bias assessment. And implementation and training will focus on the portfolio of tools that is within the remit of the group. Next. So thank you very much. Any questions, feedback, or comments would be welcome. Okay. Silvia, are you vocal now or?
I don't know. Can you hear me now?
Yes, great.
No. Oh,
We can
great. Thank you. Okay.
So,
fantastic. I'm very sorry. I don't know why had this happened because I had a very long conference call yesterday and everything worked perfectly. However, I can share my screen. Thank you. I'm sorry again.
No problem.
Okay, can you see the screen? Yes, okay. So I'm here to present the results of the qualitative studies that we conducted assessing the experience of assessors who applied grade and cinema to network meta-analysis results. For the concerned conflict of interest, Cinzia Del Giovane is a co-author of the publication about cinemas, but the other co-author have not conflict of interest in relation to this presentation. As you know, there are two approaches available to assess the confidence in NMI results, and they are the grade approach and the cinema. And as you know very well, although they share many common aspects, they also differ in the operationalization and also in some methods and criteria to download the certainty of the evidence. In the last year, we conducted a study to assess the concordance between the two approaches and to assess the interrated reliability among assessors and the application time. And we presented our results at the annual bias methods group of 2025 last year in Prague. The results of these studies has also been published in 2025 on the Journal of Clinical Epidemiology, and you can say that. In the meantime, in parallel with that study, we conducted a qualitative study to assess the perceived experience of the assessor who applied these two tools. And here I'm presenting the results of this second studies that we've done in parallel, and that has been also submitted to the Journal of Clinical Epidemiology. Very briefly about the methods, we had 13 assessors had applied grade and cinema to 4 networks that we intentionally choose of different size and complexity. As you can see, there are 2 dichotomous outcomes and 2 continuous outcomes, and the 4 networks differ in terms of number of nodes and number of loops. The 13 assessors were randomly assigned to 4 groups. Each group assessed 2 outcomes, 1 dichotomous and 1 continuous, and 1 group stayed with grade and then in the second phase assessed cinema, and the other ones started with cinema and then assessed grade, with grade the other outcome. In the meantime, for these qualitative studies, we prepared an online questionnaire that was composed by some close-ended questions on the clinical experience, the methodological knowledge, and previous experience in using these 2 instruments. And the questions question also had some open-ended question about any technical or practical challenges they could have been encountered when using the instrument, about any difficulties in understanding the theoretical concept that are behind the construct of the instruments, the need of additional skills that they thought it could be necessary to correctly apply the instrument, and then there were questions about positive and negative aspect of the two instruments, and their opinion about the usability by clinicians involved in research processes. By clinician, we meant people who have, of course, some knowledge or have adequate knowledge on the methodology to conduct a systematic review and the network meta-analysis, and also to assess the certainty of the evidence, but who are not statistician or methodologists or epidemiology who usually apply this tool, or they build these tools, so not very expert. And then the questioner ended with a self-assessment question, asking the perceived validity of the accuracy of their results. That is, we asked how they were confident about what they have done, and how much they trusted that their evaluation was correct with the two instruments. The assessor completed the questionnaire twice, once at the end of the first phase of the outcome assessment when using the first instrument on one outcome, and then at the end of the second phase when they assess on the second outcome with the other instrument. All the answers were collected and analyzed in Italian and then translated in English. The response of this questionnaire were analyzed using by two co-authors who are experts in the method for analysis of qualitative data, and they use the structure analysis and the framework analysis methods. And this analysis followed 5 stages. At first stage, each researcher read all the responses obtained. Then the two researchers independently identified the relevant themes that emerged that were of interest. Then they agreed on the teams to assign to each response, and in case of disagreement, they resolved this by discussion. Then they extracted the relevant quotation from the text, and that were divided by teams and organized in table. And finally, they analyzed the results and provided a final common interpretation of the data. So the results of this analysis identify 7 main themes. The first is the difficulties related to the instrument. The assessor reported that grade presented some practical difficulties, substantially due to the need to download, acquire and download a lot of material from the network meta-analysis that should be analyzed. For example, the forest plot of the pairwise comparison, the risk of bias table, the contribution matrix, the funnel plot, and so on. While cinema presented technical challenges substantially due to the website access and difficulty in uploading the file and so on. And these technical difficulties happened mainly with the software RobMen that was used for assessing the dissemination publication bias domain. The second themes that emerged was the need for knowledge. The assessor reported that both tools require a deep methodological, statistical, and clinical knowledge to be applied properly. And they also reported that a specific preliminary training was necessary to apply these tools in an adequate way. The third theme that emerged was related to process execution. The assessor reported that grade offer a greater understanding of the methodological steps because they are manual. So at every stage, the assessor reported that they understood and they knew what they were doing. and understand clearly all the process, while the cinema can lead to a less understanding of the methodological steps because everything is automatized. For what concerns positive aspect, the assessor reported the great access in transparency and clarity, reporting the clinical reflection, while cinema was appreciated for his speed of use and usability. The fifth thing was the interpretative uncertainty. They reported that grade carriers can carry a high risk of subjectivity because it's all manual, while cinema can create doubts in the interpretation because, as I said, everything is automatized. So in some assessors did not understand why cinema provided these results, and they had some difficulty in interpretation of that. For what concerned the further theme was implementation. Some assessors need that also for grade an automatization could be of help, while they asked for a more detailed, in-depth tutorial for cinema. And finally, for what concerned level of confidence, the assessor report they had a high confidence on what they have done with grade, but also they reported that the evaluation with grade could be subjective, while the confidence of the work done with cinema were linked and dependent to the level of understanding of the methodology that was behind the software. We think that our study has some strength and limitation. The strength is that we applied this. We conducted this study using 4 different networks of different dimension and complexity, and this could enhance the generalizability of our results. And the other factor is that we think that the feedback collected can reflect the real-world experiences of user. We could be engaged in using the tool because they are not, as I said before, they were not people who usually apply this tool in their everyday work. So they are not experienced statisticians or methodologists. The limitation is that the sample size is small. So we had, because we had 13 evaluators that when divided in group, this ended up in group of 3-4 evaluators. And the other limitation is that although both and grade were applied to the same outcome, the assessment were carried out by different individuals, or looking from individual point of view, each individual applied both grade and cinema to different outcomes. So, and this could introduce variability in the interpretation that depends not only on the tools themselves, but also may reflect individual reasoning styles. However, our conclusion, the conclusion that we were able to draw from these studies is that grade were considered slow and time-consuming, but it excelled in transparency and clarity because everything is manual, everything is done manually. While cinema was considered quick to use, but has some technical difficulties and can have a lack of understanding of the process steps. We also found that everybody thought that specific training course for effective use of both tools is necessary, and that an adequate methodological preparation is essential for a good understanding of the evaluation process. This is a good understanding of the methodological and statistical approach that are behind these tools. And of course, future studies involving the assessor of different experience and knowledge may provide further insight. Thank you. I'm completed. Just to say that if there is some question or some comments, I would like to involve in the discussion my colleague Piercarlo Partain, who is connected, because he is the expert in the methodology of the analysis of the qualitative data, and he is the author who analyzed the results. Thank you.
Thank you very much. I think Julian is first.
Hi, yes, thank you very much, Silvia. That's a really nice piece of work, and perhaps not greatly surprising. I should declare as a co-developer of the cinema framework. I guess the results are not particularly surprising, but really nice to have. So I had two points. One, I just wondering about your use of the word transparency. I think I know what you mean, but it's perhaps an awkward choice, because in terms of the usual interpretation of transparency, in terms of knowing what's happened, I would argue that an automated framework that's open source and is described in a series of publications is about as transparent as you can get, but that's kind of a trivial point. So my question really is around that series of papers that there is available about cinema, and I'm not sure, I know there are papers around the grade as well. So how much did the participants attempt to understand everything going on behind the scenes from the methodological papers, or were they just given the actual system and the guidance associated with that? My second question is one that I don't know whether you're expecting. Would you recommend one over the other?
I can start with the second question. I will not answer to this question.
Okay.
Okay, because it's really difficult. I can say that for my particular choice, but of course, I think that if cinema is really much quicker to use, is very easy, because you just need to have a simple Excel file with a few data with 4 columns, and then you put you upload the file, and then he does everything. But actually is maybe for experience that people who knows what there is behind cinema, I think that cinema was more effective, of course, while Grade is more ferruginous because he's there. But it's difficult to say. I don't want to express my opinion on that, because it could be also be difficult from several other reasons. Yes, maybe for cinema, a tutorial or a paper that tried to explain in a more easy word what there is behind the methods could be helpful. And can you please repeat the first question?
It was about how much information the participants had about what's going on behind the scenes, and whether they were encouraged to
okay.
look at that.
Yes, all these participants followed a postgraduate course on network meta-analysis that was conducted by me and by Cinzia. So Cinzia Del Giovane, you know Cinzia.
Sure.
And yes, and this course teach how to do what the network analysis is, how to do the statistical approach, and then there was 1 day dedicated to grade approach and 1 day dedicated to cinema. And then we provided all the materials. So they had all the instruments, but nevertheless they found this difficult to apply both the tools. Thank you.
Thanks.
And Isabel?
Thank you very much, Silvia, for this great presentation and great work. I was wondering whether you asked people to choose at the end, the participants, which tool they would choose, and also did you look at the reproducibility between the two, and what impact it has on the conclusion, whether we use cinema or whether we use grade?
Yes, no, we don't ask the participant what they prefer in the questionnaire, and about the impact on the conclusion, the results can be found in the other paper that is published on the Journal of Clinical Epidemiology. Here there are only the qualitative feedback. But the concordance was good. The main results of the other paper is that when for the network that are simple with few nodes and few loops, the concordance was very high, and the concordance tend to degree how much the network become complex. Okay, and then we also we tried to make several analyses comparing each tool one by one, but this now I think this is not the
Thank you.
I can yes, I can describe this now. Thank you.
think maybe, Christopher, there was a question in the chat. You want to read that out?
Yes, from Jose Meneses. He or she says, did the methods attempt to reflect the participants' technological competencies literacy in light of their feedback on automizing the systems?
I'm sorry, I don't clearly understand your question.
So so I will just read it again. Did the methods attempt to reflect the participants' technological competencies in light of their feedback on automatizing the systems?
Okay. Piercarlo, do you want to respond to this question?
Good morning, everyone. No, because we didn't need to understand what were their competencies in the technological field, because we didn't try to understand this, and we didn't discuss this in our focus group. We were focused on the clinical part and the methodological part, but not the part of the technological competencies. I think that it could be unbalanced on the cinema side, and it was not for us important.
Okay.
Thank you.
I have a question with regard to which instrument was presented first? Was it a random, or was grade always presented first, or to the participants?
They were random assigned. There were 4 groups. One were random assigned to start with cinema on one outcome, and then grade to another outcome. And the other group was assigned random to start with grade, and then to follow with cinema. So, and we had 4 groups because we thought that if I apply grade on an outcome and then cinema on the same outcome, I am of course influenced by what I've done before with the other tool. So we crossed both the tool and the outcomes, and for this reason we have 4 groups, but everything was done at random.
Any further questions or comments to Silvia? Okay, Silvia, thank you very much for your presentation, and great that you got sound at the end.
Thank you. Thank you very much.
And we'll move on to the second presentation. Giorgia, Sulis, are you ready? Even though it's in the middle of the night.
We'll try our best. All right. Good morning, everyone. The goal of this presentation is to present an overview of the methods of a recently launched research initiative related to the risk of bias assessment and reporting of vaccine effectiveness research, the ROBV project. So we are not going to present findings, but mainly methods. And one of our purposes is to gauge your interest and potentially involve you in this project going forward. In terms of a little bit of background behind this research initiative, you all know that vaccination is a key public health tool for the prevention of infectious diseases, and recent modeling has suggested that over 150 million deaths have been averted since the 70s. That is when the WHO first launched the expanded program on immunization. And clearly vaccination programs, the success of vaccination programs, as well as public trust in vaccine, are closely linked to the quality of the evidence that guides policy and practice decisions around the use of vaccines. And this evidence comes primarily from 2 sources. randomized control trials conducted mostly in the pre-approval phase to estimate efficacy and safety, and a wide range of observational studies that are extremely heterogeneous in terms of methodology used, that provide estimates of effectiveness of how vaccines work in the real world. And this is the focus of our work. As in any other field, systematic reviews and meta-analysis pull data from a variety of studies, and the quality of the evidence is dependent on the quality of included studies. So I think I don't need to explain to you all how important the risk of bias assessment is in this process, but it is particularly challenging to do this in the context of vaccine effectiveness research. And this is in part related to the type of study designs that is used, the variety of study designs that can be applied to the estimation of vaccine effectiveness, and the frequently observed inconsistent reporting quality. The fact that we don't currently have a risk of bias assessment tool that is tailored to vaccine effectiveness studies, or a tool that provides specific guidance on how to apply the various domains to the unique challenges of vaccine effectiveness evaluation, accounting for the specific mechanism and sources of bias that affect vaccine effectiveness estimation. And this might have serious consequences for the decision-making around vaccine utilization. This is essentially the rationale that led us to develop the ROBP project. It was recently funded by the Canadian Institute of Health Research. I'm one of the principal investigators. I'm alongside Melissa Brouwers at the University of Ottawa, and Cassandra here, who will continue the presentation shortly as the research coordinator. We have a number of co-investigators who are vaccine experts or methodologists. Some of them have contributed to the development of important and well-established risk of bias assessment tool like Robbins I or the Newcastle Ottawa scale. So everybody contributes disciplinary expertise to this process, and we have also knowledge users, including people in the policy side, who will also contribute. So we have two main research aims: design, validate, and disseminate a risk of bias assessment resource and user manual tailored to reducing systematic reviews of vaccine effectiveness studies, and a complementary reporting guideline, a checklist essentially, to standardize, improve the reporting of primary vaccine effectiveness studies that has been found to be a major challenge. So we aim to develop a toolkit that will include the first version of the risk of bias assessment resource, which could potentially be just an extension or an adaptation to an existing tool, not necessarily an entirely new tool, if the research findings will lead us there, and the reporting checklist. So to achieve these goals, we will undertake a multi-step process that Cassandra will now explain in greater detail.
Thanks, Giorgia. Morning, everyone. So this is an overview of the 6-step process we're going to follow, and the presentation will focus mostly on steps 1 and steps 2. Step 1 is going to involve focus groups with the public and policy decision makers to learn about their information needs and preferences. In step 2, signal items that were identified from a scoping review we recently conducted will be assessed both by the experts and methodologists. In step 3, we'll look at the usability, performance, and structure of the draft signal items, which will also be assessed by the experts and methodologists. In step 4, we'll create a rubric for translating responses from the signal items into risk of bias judgments. In step 5, systematic review experts will test the tool and the user manual on a selection of systematic reviews and their underlying primary studies. And then in step 6, we'll use data from the previous steps to create the VE study reporting guideline. So now I'm going to talk a little bit about step 1, which involves the focus groups. And the objectives here are to explore the information needs and preferences of key knowledge users regarding VE studies, and also to identify assets and challenges in the VE space to inform our knowledge translation strategy. For this, we're recruiting policy decision makers and members of the public. And for the public, we'll have 2 groups, with one group defined by age, so that's caregivers of children and older adults, and another group that's defined by underrepresented groups or individuals who may have more established perspectives on vaccination. We'll conduct a series of focus groups of 2 sessions each, with 8 to 10 participants per session. And in each focus group session, a facilitator will provide a project overview, and following an interview guide, there'll be predefined questions. There's some examples here. To the public, we're going to ask them about any recent experience they've had with vaccines, if they've been involved in discussions or overheard discussions about VE, and also about how accessible information about VE is to them. For the policy decision makers, we'll ask them if there are gaps in VE studies that make the decision-making process difficult, and whether systematic reviews adequately address questions most important to policymakers regarding VE. We'll conduct a thematic analysis, which involves an iterative coding process. The transcripts will be coded in duplicate, and a code book will be developed to guide the analysis, and we'll be identifying major themes and patterns. The steering committee, which consists of the University of Ottawa research team and our collaborators, will use the results of these focus groups to refine the development of candidate signal items, and also to shape knowledge translation activities in subsequent steps. And now I'll move on to step 2. And the objectives here are to generate a list of candidate signal items and to conduct initial content validation. And the starting materials are candidate signal items that are risk of bias concepts important to VE studies. And these were identified from a scoping review we recently conducted. And each item or concept includes a label, a clear definition, and an illustrative example. So here is an example of each. In this case, the concept label is individual level confounding bias, and the definition, this bias occurs when underlying differences in underlying participant characteristics affect the relationship between vaccination status and the outcome, resulting in a distorted assessment of the vaccine's true effectiveness. And then a concept example is healthcare seeking behavior, where vaccinated individuals may be more likely to seek medical care or get tested for the disease of interest than unvaccinated individuals. And we identified potential participants from VE studies and systematic reviews, from the World Health Organization SAGE group, from vaccine research networks, and also from our collaborators' nominations. And this step 2 will consist of 2 phases. In phase 1 will involve 15 VE experts and 15 methodologists. And then in phase 2 will involve up to 500 VE experts and methodologists. And this is to promote engagement with and awareness of the development of the tool. We'll send invitations to participate by email. They'll receive a link to SurveyMonkey to complete the survey, and reminder emails will be sent at weeks 2 and 4 of each round, and it will involve a 2 or 3 round consensus process. And participants will fill in a signal item survey where they'll be asked to rate their agreement with each statement listed here based on a 7-point Likert scale. And the statements are related to relevance, clarity, and completeness of each item. They'll also be asked to provide some qualitative feedback about how to refine the items and if there are any items missing. Participants will also fill out a response scale survey where they'll be asked to select one of the 2 options, the first being a 5-point scale assessing quality, and the second being a 5-option scale assessing information reported. For the analysis of the signal item survey, we'll calculate medians and interquartile range for each statement related to the candidate signal items. And for the response scale survey, we'll calculate the proportion of support for each rating scale. And in round 1 of the consensus process, the signal item will be retained for the next round if 75% or more of participants provide a neutral or favorable rating on these statements here, so that the component reflects a distinct quality construct unique or important to VE studies, that the concept should be included as a signal item in the assessment resource, and that the concept should be included in a reporting guide for VE study. And the retained items will be revised based on feedback. In round 2, participants will receive a summary package of results from round 1, which will include a summary of consensus scores, feedback received, and any revisions, and will follow the same procedure as mentioned on the previous slide. And if required, we'll conduct a 3rd round. Then there'll be a meeting of the steering committee who will examine the data and make decisions and refinements. And we'll also be creating a user manual to support use of the tool. And the deliverable here is the draft assessment resource, which is a finalized list of signal items and the user manual, but that doesn't have thresholds or direction for making risk of bias judgments yet. That will come at later steps. And for the current status of the project, we are currently recruiting policy decision makers and members of the public for focus groups as part of step 1. And we're also inviting vaccine experts and study design and evidence synthesis methodologists to participate in the signal item and response scale survey as part of step 2. And if you are interested in more information, we have our project protocol registered on the Open Science Framework. And in the next few days, also we'll have available our project website if you want to learn more about us and our work. If you are interested in participating or have a question, you can send us an email. And we want to thank you for your time and attention. And if you have any questions or guidance and suggestions, we'd be happy to take those now. Oh, and you're muted.
Thank you for a clear and nice presentation, and the floor is open. Andreas?
Yes, hello. Thanks. My name is Andreas Lund. Thanks for a very nice and clear presentation. I'm sorry if I kind of failed to understand it completely, but so as I understand it, by vaccine effectiveness studies, it's essentially cohort studies, right, of vaccines. You talk about it's not trials, right? Or when you use
not trials, certainly not trials.
Yeah.
So we are looking at observational studies, but not necessarily only cohort studies. So we include test negative design studies, other designs that are typically used for vaccine effectiveness estimation. Some are mainly used for vaccine effectiveness estimation and not for other types of research. And that's part of the challenge.
Yes. So I was just wondering what kind of unique properties you think there are in related to vaccines as interventions, and why not try to address them using the typical or conventional tools for assessing risk of bias, like Robin's eye for interventions, and also the stroke guidance for reporting of observational studies. It might be that you already said that, but I kind of failed to completely understand it. So maybe you can try to say what motivated you specifically to kind of that you need this kind of unique new type of tool and reporting guidelines. Thanks.
No, that's a very good point, and it's actually something we've been discussing a lot. So I think the problem is that there are mechanisms of bias and sources of bias that are very unique to vaccines and not much to, for example, medications that are tested or other types of interventions, and that relate to how vaccines are used and the population that is that receives the vaccine, and and that are not properly captured in current risk of bias assessment tools. I think one of the main challenges is that there is no specific guidance on how to apply specific items or domains of risk of bias assessment tools like Robin's eye to the challenges of vaccine effectiveness. And we found that across systematic reviews of vaccine effectiveness studies, there is a significant heterogeneity in the type of tool chosen by authors, which suggests that there is a bit of confusion and uncertainty. And sometimes authors chose to use more than one tool or modify the tool to adapt it to that particular context. And so we felt the need for greater standardization, especially for vaccine research. And we've seen that in the recent years. In times of emergency, lots of researchers who don't necessarily have the methodological expertise conduct systematic reviews and maybe don't have full clarity on how to assess the risk of bias in the studies. And this is not helping because we get a lot of, how can I say, evidence that is very low quality and leads to confusing decision making. And current tools may not be that user-friendly, especially for people without that level of expertise. So this is precisely the reason why we are not necessarily thinking of developing a very new, entirely new tool, but potentially adapting an existing tool if we feel that there is no need for major modifications or major addition. It could be more about providing information and guidance on how, maybe signaling questions on how they specifically apply to vaccine effectiveness.
Yeah, I think, Matt, you had a hand. Did you put it down, or are you still?
It was exactly the same question that Andreas asked. So
okay,
the question has been asked.
Thank you.
I wanted to add just one thing, actually. So in preparation for this study, we have conducted 2 scoping reviews that had the goal of assessing what researchers do in terms of risk of bias assessment for VE studies. And that's where we found the significant heterogeneity in approaches. And we also looked at the literature to understand what unique sources of bias and mechanism of bias are relevant to vaccine effectiveness estimation. And that's essentially the starting point for our candidate signal items that will be tested in the survey that we are about to launch as part of step 2 of the project.
Julian?
Yeah, so thanks for that. There is clearly a gap, I think, for assessing test negative designs, a good tool for that. We stumbled on one very rapidly when I was working with Isabel at the height of COVID to assess the vaccine effectiveness studies there. I'm sure it's not very good, but we had something that we could use. But you've said that you've identified unique and distinct issues for vaccine studies, but thinking just specifically for cohort studies where there is an existing tool, can you specify any of those? Because the one you used in the example is not an example. Confounding is a completely general problem in observational studies. So can you give us any motivation for the need for a new tool or new thinking for cohort studies? Although I very much welcome what you just said about you're open to the idea of a kind of implementation guidance for one of these existing tools. And I think I would encourage you to go down that route where there is one suitable for the design. But just for cohort studies, any specific issues?
Yeah, one example is the healthy vaccinee bias, or the health-seeking behavior bias that are very important in test-negative design studies.
Yeah, test negative, absolutely. But in cohort studies, where there is an existing tool, are there any distinct issues?
Not necessarily. It's more about the application, and so about providing guidance to the authors, to the researchers, in terms of what mechanism of bias they should think about when looking at vaccine effectiveness studies. It's not that the tool doesn't capture the bias itself, but it doesn't provide the specific guidelines on how to apply it. Yeah, so that's one problem, and it could be potentially useful to have one tool that allows to evaluate the various designs used to assess vaccine effectiveness, rather than having multiple tools. This could make it easier to compare studies with each other, even if the design used is different.
Any questions in the chat, Christopher?
There's no one at the moment.
Yeah, I have a question. I mean, vaccine interventions have become highly politically loaded within the last couple of years, even more than they used to be. How do you address that? Should you address that? And if so, can it be addressed in any meaningful way in a tool?
That's a hard question. Well, one way we are trying to address that is through the focus group with members of the public and policy decision makers. We are focused on the scientific aspect, for sure, and it's a very purely methodological project. But we also want to make sure that, especially through the reporting checklist, rather than the risk of bias assessment tool, we want to make sure that reporting reflects expectations in terms of the type of information that the public and policy decision makers who may not be experts of vaccine expect to see and want to better understand. Because one of the factors that contribute to vaccine hesitancy is lack of trust in vaccine research, and lack of trust may result from lack of transparency in reporting, confusing reporting. Of course, everybody needs to understand that this is an evolving field, and we'll try to discuss this during the focus group, to understand how members of the public feel about the uncertainty that is inherent to research, and vaccine research in particular. So I guess the way to address that is to promote more transparency. Yeah, improve reporting, because in the preliminary work we've done, we really found that poor reporting is one of the biggest challenges in understanding the findings reported in vaccine effectiveness studies.
Thank you very much. Yes, hard question. But I really just want to say that for some strange reason, reporting guidelines and risk of bias tool development have been not speaking very clearly to each other. And to have a project like your project where they are closely linked, I think is a great strength. So congratulations. We are on time now. We maybe have one last question. If not, then I would thank Giorgia and Cassandra for a very nice presentation. I thank everybody for showing up. It has been a pleasure and a very nice discussion. Thank you very much.
Thank you very much.
Thank you very much.